Michael Porter stated the biggest problem with ever increasing healthcare cost is not with insurers or with politics. The problem is that we are measuring the wrong things and in the wrong way. Much of the rapid escalation in healthcare cost can be attributed to the fact that healthcare providers have limited understanding of how much does it really cost to deliver patient care. And as a result, the providers struggle to improve capacity utilization rates, reduce service delays, and eliminate activities or processes which do not improve the effectiveness and efficiency of patient care. At present, most of the providers suffer due to idiosyncratic care delivery systems, poorly documented processes, and their inability to map assets and expense categories to processes. These deficiencies result in major cost wastage of somewhere between 35 to 50% of total expenditure or budget. Existing costing systems measure the cost of individual department, service, or support activity. This often encourages the shifting of cost from one type of department or service to another. The end result is micromanagement of cost at the individual organizational unit level, which does little to reduce overall cost or improve value, and may in fact actually destroy value by reducing the effectiveness of care and driving up admin cost. Furthermore, the reimbursement or payment models between payers such as insurance companies and healthcare providers is another major barrier to reducing waste. Providers around the world have structured the most important aspects of their costing systems around the way they are reimbursed by insurance companies, and are not designed based on systems or processes which clearly identify the true cost of care delivery. It is because of this reason the reimbursement models such as volume-based 1980s fee-for-service and 1983's per-case model, capitation system without quality matrix, have all contributed to suboptimal patient care and higher financial cost. We need to abandon the idea that charges billed or monies paid by insurance companies in any way reflect the true cost of patient care. In reality, the cost of using a resource such as physician, nurse, case manager, piece of equipment, or square meter of space is the same whether the resource is performing a poorly or a highly reimbursed service. Cost depends on how much of a resource's available capacity, that is time, is actually used in the care of a particular patient, and does not depend on the charge or reimbursement of the service, or even if it is reimbursed at all. Recently, there have been pilot projects in the US and Germany which demonstrated transformative effect of new approach to measuring cost at the level of an individual patient and over full cycle of care. Any costing system at a fundamental level must measure the total cost of all the resources used by a patient by tracking time durations of clinical and administrative processes as she or he moves through the system. The cost then must be compared with clinical and medical outcomes. When significant volume of such data is populated and studied in detail, the data can help the system regulators, payers, and providers to have constructive discussions among themselves. The information also provides ability to see various new opportunities, improve patient care, and achieve genuine downward shifting cost curve from within the system. Let's now talk a bit about the value-based healthcare system. The meaning of word value is subjective in nature, and definition of a policymaker can be quite different from that of patients, healthcare providers or insurance companies. Generally speaking, superior outcomes, high quality of service, patient satisfaction, timely access to care, and the low cost of treatment are the most sought after attributes. In financial context, the value is measured in terms of outputs or outcomes achieved per pound or dollar of cost. Therefore, the value is generated by improving outcomes whilst reducing the cost. In today's healthcare system, the outcomes and cost are the most powerful levers to transform the economics of healthcare. Lastly, I would like to mention a few other initiatives which are helpful for waste reduction and for improvement in population health. For public entities, the bundled capitation or population-based payment system with quality metrics and risk-sharing attributes. Integrated practice units operating under an integrated care system. The development of community engagement and support programs for prevention and education. Rationalization and tendering of drugs, consumables, and major capital expenditures. Strong internal controls over duplicate clinical tests. Request specially when originals are either lost or misplaced. And last but not least, thorough and bottom-up budgeting exercise followed by detailed monthly financial reporting and analysis. I would like to end by saying that everything mentioned here is based on my experiences and research. And if you have any comments or questions, please feel free to write to me. Thank you.